Hello everyone, this is my first time to LA. Today, let's dig into the epic. I'm Dr. Guo. Today, I want to share a topic about the modern endoscope in apical surgery. I'm Dr. Guo Yuhua from Taiwan. I'm an endodontist. I provide service at 5 different dental clinics. I'm also a senior lecturer of endodontics. The innovative surgical flow I want to share today is H.E.R.O.S, Hemostatic Endoscope Look and Operation Solution. The system designer is Dr. Tsai Wei. Dr. Tsai is a general practice dentist and an early adopter of modern endoscope in apical surgery. He specialized in endodontics and is passionate about surgery. We also show the endoscope element to International Dental Show last year. I brought this idea to APM in Osaka, Japan last year. Many Japanese doctors were interested in it. The main system we apply into the apical surgery is dynamic navigation system and endoscope. To briefly summarize, the surgical flow will be, first, we will take a CBCT for pathway design, and as usual, flap elevation or flap-based approach is possible. After bone exposure, under Navident, the pilot drill is used to walk through the designed pathway, and at this moment, we will take the second CBCT to recalibrate the pathway. And if it is on track, we will use tensor bursts for osteo guide preparation. After the guide track finished, the trifine drill is used to perform the apical ectomy. And with the H.E.R.O.S capsule and endoscope, you can easily clean and fill loose ends. And at the final step, just routine GTR or not, flap reposition and suture. Just watching the surgical flow is too hard to figure out what is going on. So I am going through a case, telling the story about where the ideas comes from and how far we can go. The new blue ocean. This is the 39-year-old female. She felt lower right first molar biting discomfort recently and a temporary crown fractured. She asked for permanent crown fabrication. The tooth was previously treated under microscope at hospital 9 years ago. And from the periapical film, we can see the filling material was not really going through the right way, but we can imagine the ex-doctor had tried much effort to find out the right path. And also, we can see the PDO widening and small lesion noted in apical area. The diagnosis was previously treated as symptomatic apical periodontitis. The reasonable treatment plan should be non-surgical retreatment or apical surgery. Since the patient had tried treatment under microscope and root canal transportation noted, it was difficult to regain patency and time-consuming. So, considering the cost-effectiveness, we decided to go for apical surgery. And these are intraoral photos. Soft tissue are smooth in buccal and lingual area without sinus thread. And in the CBCT image, we can find out apical lesion in coronal and sagittal view. The image information will be used to design the navigation pathway with the Navident system. The data input in the Navident software, the implant mode was applied and reorientate the insertion direction, adjust the property like width or length, and different diameter analog in different steps. Then we positioning the tip on the landmark to superimpose the image to the surgical area. And during operation, we monitor the screen and try to target the center. And when switch the pilot drill to tensor burr, we need to calibrate the tip. And after the script finished, we can start surgery. After flap elevation, bone exposure, we use pilot drill with Navident system to confirming the pathway. Here, and then we take the second CBCT to check the position. And as you see, the vertical angulation here may be good, but the horizontal angulation here was slightly deviate and need adjustment. And after a little adjustment, we will check in if the path is on track. The tensor burrs were used to expand the surgical window, move deeper to create a surgical guide for the trifine drill. Then we can precisely cut 3 mm root with the trifine drill. The term precise root and resection. This is very important, especially in posterior or non-visible area. If you have ever used a trifine drill on bone, you would know how challenging it is to control along a stable path. It's always bouncing, Most of the time, we need a guide, a rigid surgical guide. This is the traditional printed surgical guide. The main difference between Asian and Western people is the oral cavity space. In Asia, people often have tight buccal cheek and smaller mouth. Traditional surgical guide occupied too much buccal space. This restricts the use in posterior teeth. Or when we use the dynamic navigation system only, the treatment drill will bounce and when work on the cortical bone surface. And if you are not a talented video game player, it's quite difficult holding the treatment drill and targeting the center at the same time. So for precise root and resection, dynamic navigation or rigid surgical guide, which one is better? Or we can use both, go for an osteo guide. Navigate the pilot drill toward the root tip. Because the pilot drill is sharp and small, it isn't bounced on the bone surface. Not only easier to be controlled, but higher deviation tolerance than the treatment drill. Then after confirming the pathway, we use the denser burr. It bends to create the glide path. The cortical-like tunnel here turns into a rigid guide, serve as a trajectory for treatment drill. The concept of root canal enlargement is compatible in osteo-guided root and resection. In root canal enlargement, we use the negotiating file, then check booking length and prepare glide path, then shaping the canal. And in root and resection, first we use pilot drill with Navident, then we check CBCT to check if it is on track. Then we use denser burr to go for a trajectory. Then finally, we use the treatment drill to cut the root tip. Both of these steps are for glide path preparation. These are Verja denser burrs. They are designed for implant surgery. Different diameters here are also suitable for creating a surgical window in apical surgery. Denser burr compacts cancerous bone by non-cutting reverse rotation. It compresses the bone and deforms it into a cortical-like tunnel. And this tunnel serves as the trajectory for treatment drill. The counterclockwise non-cutting rotation provides not only cancerous bone compression, but also soft tissue protection. Compress the cancerous bone, prepare the osteo guide, and also perform high-efficient hemostasis. And the non-cutting rotation means you can enucleate the cyst in one piece. And also, when you manage it in sinus proximity area, the membrane will be pushed rather than be perforated. This is my case. The upper right second premolar, the root tip was close to the sinus floor. Here, in order not to penetrate the sinus, I cut the root tip at the set point with high-speed diamond burr. Then I use the denser burr with reverse rotation to create the surgical window for working space for retrograde preparation. And let's back to the case. After root and resection, then we are ready to prepare with retrograde management. Here are endoscope setting elements. The diameter 2 mm endoscope with LED light and camera. Very thin, flexible, and easy to be inserted to multi-direction. And the H.E.R.O.S capsule and the clip. And set them up like this. These are product photos. You can see the capsule, the clip, and the endoscope. The expand bone window diameter is 6 mm. The capsule inner wall is 5.5 mm. Endoscope needs 2 mm, and the ultrasonic tip needs 3 mm. The size 6 mm is as small as the straw of Starbucks. Very conservative preparation. And obviously, the capsule needs to be appropriately trimmed. I left 4 mm tube outside the bone. Then I will create a 3 mm notch toward the bone surface. Okay, the 3 mm here, the entry for ultrasonic tip, and this 4 mm, it holds clip of endoscope and provides support for flap retraction. Then we attach the endoscope to the clip and insert it to the capsule track. Then we use pliers to align the capsule toward the apex. Then we can check the surgical area through the observation port. And this is the view from endoscope. Here is isthmus, and here is the mesiolingual canal. The ultrasonic tips cleaning the root apex with real-time monitoring through the endoscope. The surgical view is always clear. You don't have to repeatedly use micro mirrors for checking. And then we can pay attention on this track. The pathway directs blood flow away from the surgical site. And retrograde filling with MTA. Clear root and filling was accomplished. And these are follow-up films. This is another case with 2 roots and resection and retrograde filling, then the follow-up. The results are good. About the story of endoscope, we know that technology always comes from needs. So if you want to see the tiny things clearly, maybe you can magnify it. And this is microscope. Or we can magnify and get close to it. This is endoscope. In 1853, the father of endoscope, Antoni Gindesimo, a neurologist, his device would be called a cystoscope today to see inside the bladder. And in 1951, an English physicist, Carl Hopkins, his wave theory of vibration, the new telescopic lens system, creates an image of outstanding resolution and contrast. In 1975, by Masatoshi Onishi, the first use of endoscope in dentistry for seeing inside the temporomandibular joint. And in 1979, the first use in endodontics, with a pediatric cystoscope insert into the access opening. Then we can check this. Then here is a crack, and here is gutta percha. As you see, the image resolution is quite bad. And in 1996, the endoscope used in upper right first molar palatal root surgery. The rich long tube used in this area is very challenging and looks horrible. And in 2009, a series of cases used 6 centimeter long and 3 millimeter wide endoscope with modern apical surgery concept. But pay attention on the scope, it's still rigid type. So, till 2022, the modern endoscope used in apical surgery. You can see the flexible, tiny with LED light and camera. Very impressive. The image is clear, colorful, and high resolution. The innovative surgical flow first use CBCT to design the pathway, and as usual flap design, flap elevation. Then we prepare for steel guide, then use the tripine drill for apical ectomy. And with the help of H.E.R.O.S capsule and endoscope, we can easily manage the two ends. At the final step, just routine GTR, flap reposition, and suture. The full set of apical surgery costs in Taiwan. Endoscope with capsule maybe $4,000 to $5,000, and the navigation system around $30,000. And if you don't have dental burrs, you need to pay extra $3,000 for the set. If you do a quick calculation, you may think, wow, Taiwanese are so rich. The full set of apical surgery is expensive. Actually, can you guess how much the surgical fee is in Taiwan? Apical surgery per tooth included GTR. How much? Can you guess how much? In Taiwan, the apical surgery includes GTR in Taiwan. The fee is less than $2,000. I introduced the case to Dr. Kim last year, the master of apical surgery. His primary concern was that the full set equipment and cost of this apical surgery are unreasonable. It's not easily accessible for every single clinic. True, faced to the reality, the clinic and hospital is a charity. We still need to make ends meet. So we should pay attention to the flexibility. Its flexibility is unlimited. The full set of apical surgery, endoscope, capsule, navigation system, maybe it's too luxury for easy case. We can treat them by meal set. The super combo for simple case, dual lesion, anterior teeth, mega combo for larger lesion, posterior teeth, or ultra combo for extreme complex case. Capsule is not necessary for these cases. Shallow lesions, you can use endoscope to check the end directly. You don't need a capsule support. And in deeper or larger lesion, the capsule helps inserting endoscope toward deeper and control the surgical view. And in complicated case, navigation was applied for precise group and recession in difficult approaching area. This makes second molar surgery possible, or even difficult approach the palatal route or distal lingual route. No doubt that so far, the resolution and delicacy of imaging microscope is the best. Here, the endoscope is not meant to challenge the microscope, but it do have the improvement in apical surgery. It's more flexible, suitable for anterior, posterior, visible, non-visible area, and it's more accessible for doctor and more comfortable for patient. No need to stretch the patient too much just for a clear view, and it saves time because the view is always clear. You don't need to use micro mirror repeatedly, and you can take videos and photos easily. Of course, the price of endoscope is much lower than microscope. In Taiwan, more and more doctors are willing to try this new tool, and in Japan, some hygienists use it for dedicated scaling. I attended Dr. Yoshi Terauchi's hands-on course in Tokyo last year. One of the slides inspired me a lot. If you do what you always done, you will get what you always got. So always try something different. At this moment, Dr. Tsai is still working hard to realize his new idea. This is the new version capsule, the capsule with micro mirror. It enhances the field of view. After the mirror reflection, you can see the end directly through the endoscope. And the new idea, EndoPen. Attach a handle to the endoscope. It can drive you to any direction with many different tip elements suitable for apical surgery, periodontal treatment management, or tooth preparation. This is news about Apple's Vision Pro being used in surgery. In the future, we might see the dental navigation system, endoscope, and Vision Pro all made together in dental treatment. Last year, the NVIDIA CEO, Jensen Huang, tells NTU grads, run, don't walk, whatever it is, run after it. Yes, the future is coming, run for it. Here are 2 reasons why you should try endoscope right now. First, it's free to try now, just like walk in Apple stores and enjoy new product. If you have the opportunity to try something new, why not take it? And second, in the early stage of the new product, there is always unlimited potential. It's happy to have the chance to share my experience here. Thank you for your attention, and this is my contact information. Here are my WhatsApp and Facebook links. The endoscope is now available in these 2 companies. The distributor in United States is pending, but you can try it by contact H.E.R.O.S. To find out more detail, you can scan here to visit the YouTube channel.